When it comes to health, few words are as controversial as cholesterol, and few medications spark more debate than statins. But behind the headlines, the myths and influencers are real people trying to make the right decisions for their heart, their brain, and their future health. My guest today is Dr. Marc George, a physician, researcher, and teacher. But more than that, he's someone who cares deeply about helping people understand their cardiovascular risk in a way that actually makes sense. In a way that's not fear-driven, not medication-pushing, but with clarity, compassion, and most importantly, with scientific evidence. In today's conversation, we're cutting through the noise on cholesterol, statins, and heart health. What actually matters? When should you act? And is there an argument that we should all be taking a statin? Marc, welcome back to The Health Perspective.
Thanks for having me again.
Cholesterol has such negative connotations, well, positive and negative connotations, but we tend to think of it as a bad thing. Give me a quick summary on cholesterol. What is it, and why do we worry so much about it?
Thanks for having me again. So cholesterol is really important. We all need cholesterol. It's actually a vital part of every cell in our body. In fact, the outside of all cells are predominantly made of cholesterol. We need it to help make certain vitamins. We need it to help make bile and digest our food. So cholesterol is a necessary part of our diet, and something that our body, makes lots of. The controversy obviously comes around its association with heart disease, things like heart disease and stroke. And we've known for a very long time that there is a very clear association between your cholesterol in your blood and your risk of having things like a heart attack and stroke. And that's been known about for decades. I think some of the controversy has been around diet and cholesterol, because if you look at those graphs and you see that you're a much higher risk of having a heart attack or stroke if your cholesterol is higher, I think the initial reaction was, well, you should have lower cholesterol in your diet. And there were advice, from governments a few decades ago to really restrict the amount of cholesterol that you have in the diet. For example, egg yolks being a very common source of cholesterol. But it actually turns out that dietary cholesterol isn't one of the main things that pushes up the cholesterol in your blood. In fact, most of the cholesterol in your blood is actually made by your liver. And there are other things that stimulate your liver to make cholesterol beyond dietary cholesterol itself. So actually the advice around dietary cholesterol has changed over time. And I think that's where some of this confusion comes from. And in fact, in the diet, some of the things that push up your cholesterol are things like bad fats. So things like saturated fats, trans fats, but also things like sugar as well. So there are other things in your diet that actually push up your cholesterol rather than cholesterol itself.
So if we think then about cholesterol, I think one of the things and one of the habits I was in as a GP, and I kind of guess I still am in now, is describing different types of cholesterol as good and bad. And I think many of us still do that, but it is a bit more nuanced than that. So could you just talk us through the different types of cholesterol and how we should think about them?
So as we just said, there is this association between higher levels of cholesterol and heart disease. But like you say, cholesterol breaks down into lots of different types. And the two main types of cholesterol are something called LDL, or low density lipoprotein. I won't call it that again. LDL, and one called HDL, which is high density lipoprotein. And these are kind of seen as sort of the bad guy, the LDL, and the good guy, the HDL. And the reason for that is the LDL is the one that's made by the liver. It's packed full of cholesterol, and it leaves your liver and it travels around the body and it distributes into places where it's needed. But the problem with that is it can sometimes end up in the wrong place, which is in the blood vessel walls themselves, where it builds up into something called atherosclerosis, which is this sort of fatty deposition in the middle of arteries. And that's what leads to things like heart attacks. So that's what's considered the bad guy. And when you take that graph that I mentioned, it's the LDL, the bad cholesterol that's associated with heart disease. The good cholesterol, the HDL, this does the opposite. This actually takes cholesterol away from places like the blood vessels, takes it back to the liver to get rid of it. So that actually helps to reduce your risk. So actually, when you look at HDL and its association with heart disease, it's the opposite. So a higher HDL actually protects you from heart disease and stroke, whereas the LDL is the one that increases your risk of heart attack and stroke. And obviously it is a bit more nuanced than that, but that's why you hear about good cholesterol and bad cholesterol. And when we're thinking about lowering somebody's risks of heart attack and stroke, it's that LDL that we are trying to lower, not the HDL, which actually we would like to be higher.
And is there a way we can increase the HDL? I know that there's really no medications that will do that. But in terms of lifestyle, is there anything that we can do to push up that good cholesterol, the HDL cholesterol?
So there are certain things that have been shown to have a sort of modest effect on raising HDL. So some lifestyle factors like dietary factors. So for example, polyunsaturated fats. If you if you replace bad trans and saturated fats with polyunsaturated, the sort of thing you find in olive oil, that actually can have a positive effect. And things like exercise can also have an effect on HDL. But as you say, it's much harder for us as clinicians to do something beyond that, because like you say, there are no drugs so far that have worked that have pushed up HDL. There are a few drugs that were tried and failed when they went through the sort of process of approving drugs. So most of the drugs that we have are focused on lowering LDL, but we don't have that ability to raise HDL beyond some of those lifestyle factors.
And you touched on the fact that diet isn't necessarily as important as we used to think for LDL. How important is it? I mean, it's a two-part question. How important is it? And I guess what other lifestyle things can we do to reduce our LDL cholesterol?
So diet is important, but cholesterol in your diet is less important than we used to think it was. It's actually those other things I mentioned. So things like saturated fats, trans fats, which are these artificial fats that you find in a lot of processed foods. Lots of sort of processed baked goods, for example, have a lot of trans fats. And there is evidence that if you can replace those in your diet with good, healthy fats like polyunsaturated, then actually that has a benefit in terms of lowering your LDL. Again, things like exercise, reducing alcohol, these are things that can help reduce your LDL in terms of lifestyle. So there are definitely things that you can do. Exercise is also very good at helping to lower your LDL. So there are definitely lifestyle approaches that can give you a much better, what we call sort of lipid profile. So a sort of lower LDL and a slightly higher HDL. But when we get on to talking about the medicines, it's the medicines are the things that can have a really big impact on reducing your LDL levels.
And what about the role of new markers? And there's a lot of talk in the longevity space about two specifically. One is lipoprotein(a), and I've done a separate kind of video on that. And the other one is apolipoprotein B. And people are getting more interested in having these, specifically these two markers checked. How important are they? Kind of how do they fit into the picture?
So I think Lp(a), it's an interesting one. So this is another fat that your body makes. And why it's interesting is if it in separate to all the other cholesterol markers that we look at, it independently is associated with heart disease risk. And actually what's really
so that
interesting...
means that if all your other ones are normal, but this one is raised, you can still have
So you can have a low LDL, but your Lp(a) has got nothing to do with your LDL and could be high, and that will put you at risk of heart disease. And that's become increasingly recognized. And what's interesting about Lpa, and I'm sure you covered this in your other video, is it's inherited. So it's very strongly inherited from your parents. And so sometimes you have families where lots of people in the family have had premature heart disease, heart attacks at a young age, and actually the cholesterol's normal, and you measure the Lpa and that's very high. And that probably explains some of that increased risk in some of those families.
It's the hidden, I describe it as the hidden.
And and I think one of the reasons it's been hidden is we can't really do much about it at the moment. So statins, which we'll talk about, which lower LDL, don't really affect Lp(a) very much at all. But there are new drugs in development which are going to specifically target that Lpa. So for those families, or those people at high risk who have a high Lp(a), soon in the next few years, we should have a medicine that can directly reduce Lpa. So I think because we didn't have a drug or something that we could do anything about it, measuring it might inform you in terms of what else you do. You might say someone with a high Lpa is at risk. We should lower all their other risk factors like their LDL and their blood pressure. But now, in the next few years, we're going to have a drug.
Well, that's always my argument when I do a test with a patient. The primary question I'm asking is this test going to change anything? So should we be doing this test because can it change anything? But my argument with Lp(a) is always that it can, because we then just become so much more aware of the need to be more aggressive on those other risk factors. So yes, correct, I can't give a medication to lower it, but I can say, because your LP little a is in this really high risk range, actually your risk of heart disease is so much higher than average, and we just have to completely tackle the rest of those risk factors as aggressively as we can. So I think whilst there's no direct medicine, I think there still are some downstream effects. And
yeah, no, I completely agree. It's for those people where you're in the middle. If you're somebody who there's a convincing reason to be aggressively reducing their risk factors, so their cholesterol and the blood pressure, you're going to do it anyway.
Yeah.
If there's those people in the middle where you and the patient are undecided, LP(a) could be the thing that decides you one way or the other. Whether to start a medicine, for example, at that stage. ApoB100, I think, it's a protein that sits on LDL, and measuring it can add a little bit of extra information, but not a huge amount. I don't think it changes much when you've got a high LDL. The ApoB100 is just part of that LDL protein. Whereas I think LP(a) is much more interesting because it's independent of the things that we normally measure.
And neither of them, but specifically the LP(a), are not tested in regular cholesterol profiles. So most people won't know.
You have to ask for it specifically, rather than just ticking the box or clicking for the lipid profile.
How much of a role does genetics have? And the reason I ask is because I see this with quite a lot of patients who actually have reasonably good lifestyles. They exercise a lot. They eat well, and I trust what they're telling me on that front. They eat well, they have a normal weight, and their cholesterol is still really high, kind of 6.5, with an LDL of 3.5, fasting 4. And they're just so frustrated. And we sit and we have these conversations where I know I can't tell them to try harder necessarily. So what do I say to those patients? So how much does genetics play a role here?
It's huge. Before we get into that question about what you say to those patients, genetics is really big in the cholesterol space. So we have conditions where a change in one gene can really increase cholesterol hugely. So the genes that control how LDL is processed in the body, if they are altered, you get families where cholesterol is really high from a young age, and those patients develop heart disease at a young age. So even if they have one copy of that gene, they will develop heart disease in their 20s and 30s. And it's one of the bits of evidence that tells us that LDL is really important, is that you have these families who develop heart attacks in their 20s and 30s because their cholesterol is so high, because they have a change in one really important gene. So there's a handful of those genes, maybe 5 or 6, where a change in one of those genes is so powerful that their cholesterol goes really high and it causes heart disease. But beyond those, it's not that uncommon actually that you have families, and we will screen for that. It's called familial hypercholesterolemia. There are dedicated lipids clinics where they'll be seen, and we will aggressively treat those patients and their children from quite a young age to keep their cholesterol nice and low, from as soon as possible. But beyond that, in the probably the majority of patients, there are probably around at least 95 genes that have been identified that push up your cholesterol, but not in the same degree as one of those 5 or 6, by a small amount. And you can inherit any number of those 95 changes, and it's like a cumulative effect. It's called polygenic risk. So you would have accumulated 10 or 20 or 30 of these small changes, and cumulatively they push up your LDL. And then you add to that lifestyle. So you take your risk because of your genes, you add in lifestyle, and some people will be more sensitive to changes in things like their diet and exercise than others because of the genes that they've inherited. So those patients that are frustrated because they seem to be doing everything right, they may just be one of these people that have a high number of these changes. This polygenic risk can be quite high. For those patients, you may need to move beyond lifestyle to help them lower their cholesterol.
And what about the genetic influence of what the cholesterol does in the body? Because again, we see patients with a normal cholesterol who have heart disease at a young age, or a moderate age at least. So to what extent does genetics and lifestyle influence, even if you're measuring the cholesterol and it's normal, influence the way that cholesterol deposits and gives us those atherosclerotic plaques inside our arteries?
Yeah, I mean, it is interesting because you do see some patients that have high cholesterol don't seem to have any heart disease. They are rarer than people where they have high and you expect to see heart disease. And it's probably to do with a few things. I mean, there are probably very important but subtle changes in the type of LDL and how much it is likely to be deposited, which is not something you can readily measure, using standard blood tests. And there are other factors. So it's not just the cholesterol. There are things like blood pressure, lifestyle, diabetes, smoking, other factors in addition to the high cholesterol that cumulatively increase your risk. Inflammation's another one. So patients with chronic inflammatory diseases like rheumatoid arthritis, that pushes up your risk. We begin to recognize that actually mental health disorders push up your risk. Certain drugs, recreational or other, push up your risk. So there are loads of risk factors that have been identified. Yes, cholesterol is one of the big ones, as is things like blood pressure and diabetes, but there are a whole host of them that cumulatively add up. But on an individual basis, you will find people who have been lucky and had high cholesterol.
They're the outliers.
And they are more the outliers. They are not, they're exception that sort of proves the rule. They're not the sort of usual type of patient that you find.
Yeah, I think what you mentioned is something I'm very passionate about. And I think it's again where GPs look at the patient from a whole body perspective. When I have patients with chronic inflammatory conditions, specifically things like rheumatoid arthritis and also skin conditions like psoriasis, often the specialists are excellent, but they're looking very much at the skin. And I will often in clinics say, this is an independent risk factor. And most of the risk calculators that we use don't actually measure risk in those patients as well. Yeah. So it's really important for those people to take a really individualized approach.
Yeah. And I think, I've got lots of colleagues who are rheumatologists who are becoming increasingly more aware that they don't just want to address the arthritis, but they have to realize that is part of a bigger picture and be offering them things that are going to protect them, from heart disease, lower their cholesterol, lower their blood pressure. And actually the latest, there are these national risk calculators where you can work out somebody's heart disease risk. The latest versions do include a lot of these newer, more recognized things like have they got lupus, have they got rheumatoid arthritis. So those are included in the risk calculators now.
Before we move on to talking about medicines, I just want to ask what conditions can cholesterol cause? Or if we're thinking about someone with a poor cholesterol profile, so an raised LDL and a low HDL, we obviously instinctively think about heart disease and stroke. But what's the kind of different plethora of illnesses and long-term diseases?
So the underlying kind of disease process in arteries is where that cholesterol deposits in arteries. So you can imagine arteries then start to narrow with time. And then one of the concerns is when that kind of cholesterol, it's normally stable, but sometimes it ruptures. And what happens is you get a clot that forms on top of it. And you can imagine that then blocks the artery entirely. And that can happen in any artery in your body. So it depends where that process happens, gives you the kind of the consequence. So obviously people are aware if that happens in your heart, you get angina, so that feeling of chest pain when you exercise, because the narrowing doesn't allow enough blood flow to make up, your muscle needs more blood, more oxygen when you're exercising. And because of the narrowing, it can't get that blood and oxygen, and it manifests as pain when you're exercising. And those patients, then they rest and it gets better. So that's called angina. But then if it ruptures and the whole artery blocks, the downstream muscle in the heart starts to die, and that's called a heart attack. So in the heart, you get angina and a heart attack, but similar things happen elsewhere. So in your brain, when it's furring up, that actually is a cause of dementia. That's called vascular dementia. It's one of the leading causes. But if something ruptures, you can get a stroke. That can be a blockage stroke, or it can be a bleeding stroke. But it happens in other organs. It can happen in your gut. You can have what's called gut ischemia as a result of this. So your gut starts to die, which is obviously a medical emergency. It can happen in your kidneys. And in the kidneys, you might not be aware it's happening. It might not give you any symptoms. But actually a blocked artery going to the kidney is then screaming for more oxygen, and it pushes your blood pressure up. So one of the things we look for when people have unexplained high blood pressure sometimes is there any furring up in the arteries that go to the kidneys? It can happen in your legs. So people who get a similar thing like angina, but in their legs, so they walk, they get really painful legs when they're walking because they're not getting enough blood to their muscles. And when it's really bad, if it's completely blocked, you can get gangrene. Your foot can turn black and need to be amputated. So it can be really extreme. Obviously, those are extreme cases, but we see that in the hospitals all the time.
And the key is what you're saying is it's having a raised cholesterol on one day, just like your blood pressure isn't going to do you any harm, but it's the cumulative effect of that cholesterol over many years which causes the problem.
That's the key point is, and we're going to get onto this when you say, well, when should you start lowering it? But actually the damage, these plaques, we call them, these places where cholesterol is depositing, that can start in childhood. And by adolescence, early adulthood, some of that will be quite significant. So it actually starts quite young. And so by the time it kind of manifests itself in your 50s and 60s, it's often very far down the line. And so some people will argue that the sooner you start to lower the cholesterol, the better. Because by the time you think about starting it, often people have already got the build-up of, the cholesterol, the third arteries have already started. So there is that, school of thought, and there's lots of evidence behind this that starting earlier, trying to lower your cholesterol is better than waiting.
So let's talk about medical ways we can lower cholesterol. And I think really this is a conversation about statins, because whilst there are newer medicines and other options, statins are the mainstay of what we have available in terms of prescription options. And I think my perspective as a GP is that these statins get often a bad rap, and people approach them with a lot of suspicion. But I'm increasingly coming to understand that these are extremely good medications. They've been around a long time, haven't they?
Yeah.
But give us a little bit of an explanation on how they work.
Yeah. So I'm a big fan of statins. So I'm going to start with that. So anyone watching who isn't, I will explain why. So you're right. These drugs have been in and around since the early 90s. They're one of the most commonly prescribed drugs worldwide. I think in the UK, 40% of over 70s are on a statin. They're really common. And the reason is that they reduce, remember I said that the liver makes about 80% of the cholesterol that's circulating, and they reduce the amount the liver makes. So that's how they work. And they can be really quite powerful. So that LDL cholesterol, a standard sort of statin, what's called a high intensity statin, but it's the standard one we use, will lower that at the initial dose by about 40%. And at higher doses, we'll get up to about over 50%. So you can halve the amount of LDL that's circulating. And if you do that, it doesn't matter what your LDL was to start with, you will reduce your risk of heart attack and stroke by about a third, 30 to 40%. So they have a really big impact on reducing LDL, and that translates to a really big impact on reducing your risk. And that's been proven in, multiple blinded clinical studies, and even the newer drugs, which aren't statins, which can lower things even further, have gone on to show continued benefit. So the lower you get the LDL, the better. In fact, we haven't yet found a point at which you can continue to lower the LDL and it doesn't still translate to reducing your risk of heart attack and stroke.
So what you're saying is it reduces the risk by a third regardless, but if your overall risk is kind of 3%, then you're going to go down to 2, which may not be that meaningful.
Exactly.
But if your overall risk is kind of 20%, you're going to be coming down to kind of 13%, and that is a huge reduction.
Yeah, so you're touching on something called the difference between absolute risk and relative risk. So like you say, your absolute risk might be 3%, and your relative reduction at 50% only takes you to 1.5. So you've only dropped your absolute risk reduction to 1.5. So it is important to know what your baseline risk is. But that risk that you're talking about is probably a short-term risk. It's like a five-year risk or a 10-year risk. If you look at lifetime risk, though, it really changes because this is the most common cause of death worldwide, is diseases related to atherosclerosis, so heart attack and stroke. So if you look at it on a lifetime basis rather than on a 5 or 10-year basis, which is a lot of the calculators do, then you can understand why lowering cholesterol over a lifetime is going to be beneficial. But then we get and touch on, how long should you be taking a tablet for, and should you be taking it for life? But the headline is, in terms of why statins are net good, they really have a strong impact on reducing LDL, and that translates to this relative risk reduction by about 30%.
And they also have other. I mean, I think people traditionally have seen them as my cholesterol lowering medications. My cholesterol's too high. I need to take a statin. But they have a number of other really important effects, don't they? And this is something, again, I need to fact check on. But from my understanding, they also reduce the cholesterol build-up on arteries, and they can even stabilize plaques that are already in the arteries.
Yeah.
Are those effects important too?
Yeah. So I think these additional effects, they're all additional benefits. So stabilizing these sort of deposits of cholesterol, I said they can rupture and cause a heart attack. There is evidence that statins can actually, like you say, stabilize them. They also seem to have an anti-inflammatory effect to some extent as well. And we know that inflammation is, as we mentioned, another sort of risk factor. So they have this additional benefit. Their mechanism isn't just lowering LDL. There are other things that it does that are of benefit.
So the obvious question is going to be, what are the risks? What are the costs? And before we talk about side effects, because that's a whole topic in itself, are there any known long-term downsides or risks of taking statins?
So if you take beyond the sort of side effects, as you're saying, if it's talking about lowering LDL itself, I'm not aware of any specifically related to lowering LDL. In all of the big trials, when you would ask, well, surely you need a certain amount of LDL, we haven't yet found that point where lowering it isn't beneficial in terms of reducing risk of cardiovascular disease. So I don't think there is. Unlike blood pressure, whereas if you get too low, you're going to pass out. That's not the case with LDL cholesterol. But side effects, I know is something we wanted to talk about. When you've got patients coming into your practice and you're suggesting starting a statin, do you get reluctance? Do you find that people
a huge amount of reluctance. And that doesn't come from a bad place, but I think over the years, like with many things like kind of HRT and other things, the stories moved so much on statins, and the publicity around muscle cramps and muscle aches, and then more recent studies that a lot of that was actually kind of the nocebo effect, so people getting side effects just because they knew they were going to get them. So I think people don't really know where to stand on it. And I think people's general approach in life, and this is an approach I support, is that they would rather not take a medicine if they don't need a medicine. But statins kind of, in my mind, are starting to fall out that category. Because it's, I think the more research that comes out, it's not necessarily the case. But it's hard to tie that up with the I'd rather not take something if I can avoid it. So, yeah, I think there is generally a lot of suspicion around statins. And I think people come in expecting that they're going to have really unpleasant side effects.
Yeah, I think the side effect issue with statins is that they've had a lot of negative press, a lot of negative publicity. And I think that really affects patients and how they approach it.
Yeah.
And like you said, one of the main concerns is the effects on muscles and people saying that they're going to have muscle ache, muscle cramps. But when you look at the evidence, if you look at the trials, so there's been lots and lots of trials with hundreds of thousands of patients who've taken statins. And if you pull all that together, it's something called a meta-analysis. We take all of the information from lots of different trials and you look at the rate of muscle pain in those trials. You can look at the rate in the people that took the statin, and you can look at the rate in the people that took a placebo. And what's interesting is the rate is almost identical, and it's quite high. So in the placebo, it's around 27% of patients having some sort of muscle effect on a placebo. So that's a dummy pill. And very similar, it's just 0.5% more in patients on a statin. So yes, it was slightly more, but the vast, vast majority of the muscle side effects were not to do with the statin. They were just the rate of muscle effects in the population. I think that's really important to tell your patients that even though muscle effects do happen, they actually are very rare. So that was about 1 in 200 when you look at that evidence. And the study that you just mentioned, this nocebo study, is called the Samson trial. So they took patients who'd previously had a problem with statins, and then the same patients got rotated between a statin, a placebo, so an actual pill, but it wasn't effective, didn't do anything, and nothing. And in doing so, they measured how much side effects they had related to muscle ache, for example. And 90% of the symptoms that the patients reported, they had on the statin and the placebo. So they flipped it. They call it a nocebo. So you going in with a negative thought about a statin has the opposite effect of a placebo. It makes you feel worse rather than better. But if you explain that to patients, that there's really good evidence that that the rate of muscle effects is actually very small, I think that really helps at the get-go. Put that to bed if you can at the beginning. Now, it's not to say people won't have the side effects. I've met lots of patients that have.
Yeah.
And they are often real. And you need to recognize that. But there is an approach to dealing with that, in terms of taking them off the statin, seeing if the pains subside, re-challenging them to see if it comes back, because that builds the case that, okay, it was probably the statin. And then there are multiple different statins you can try before you say, actually, statins do not get on with you, because you might find a different statin doesn't have that side effect. And there are at least, 3 or 4 common statins that we can try. And beyond that, if statins are a problem, there are other medicines that lower cholesterol, not necessarily as a tablet form to the same degree, but there are good options that, newly available drugs that are alternatives to statins that don't seem to have the muscle side effects.
So when you're counselling a patient and starting a statin medication, what side effects do you warn them of?
So I do mention the muscle, actually, but I do also put it in that context. Because there are very, very rare instances where the muscle side effects can be severe, but they are rare, so it's worth mentioning. And we also do need to keep an eye on people's liver function as well. So the liver sometimes also, the sort of liver parameters sometimes go up, and we need to keep an eye on that too. But otherwise, I say they're generally very well tolerated. And a bit like the blood pressure conversation that we had, you're not treating a symptom. You're asking people to take a pill every day that isn't going to make them feel any better. So I think you really have to make the point about them reducing their risk. And that's where I think it's quite powerful when you measure their cholesterol 3 months later to see that it's come down by 30 or 40%. That can really help reinforce the idea that they're having a good effect. And then again, you can talk about their individual risk and how that's come down as a result of reducing their cholesterol levels. I think it's probably also worth making the point there is a difference between patients who have never had a heart attack and stroke and those that have. We'll always try and put people on top dose of statin if they've already had a heart attack or stroke, to try and reduce their risk of future what's called events, future heart attacks and strokes. And that is effective even after you've had one before. But actually, it's probably better to prevent it in the first place. Yeah. And that's where this thing called primary prevention. So particularly people who are at high risk for various different reasons, they might have a combination of things like high cholesterol, but also high blood pressure and diabetes, or a strong family history. And, in those patients that are higher risk, we should certainly be offering statins in addition to lifestyle changes that can help lower their cholesterol.
I guess that brings me on to a question of personal interest, which is, given the immense benefits and the lack of clear kind of harms with statins, how early is too early? And for many people, myself, I'm, just over 40, and I don't have a huge amount of lifestyle risk, but I do have a family history of heart disease. Now, if I was to use traditional calculators, I would fall at a low risk level according to kind of national guidance and wouldn't be appropriate for a statin now. Maybe by the time I turn 55 or something, I would qualify for a statin. But my argument would be, well, if I can start to reduce my cholesterol and cholesterol build up on the arteries now, should we be taking statins earlier?
So there is a very strong argument for that. There is a field of research called epidemiology, so looking at things on a population level, and trying to understand, as a population, if we were to offer everyone a statin at a certain age, would we prevent thousands of heart attacks and strokes? The answer is probably yes.
Like a vaccine.
Yeah, essentially. And so some researchers will argue that's at age 40, others 45, but it is between 40 and 50, some people argue, on an age-based, because again, age is one of the biggest risk factors. Because you've accumulated a lot of that build-up by that age, you're better off, starting earlier rather than leaving it later.
Right.
In terms of your overall risk, I think as an individual, you have to make your own choices. You have to put to somebody, do you want to take a tablet every day, potentially for the rest of your life? Is that something you're willing to do? how do you sit personally with risk? We've talked about NICE, which is this national body that sets guidelines. And interestingly, the old guideline said if your 10-year risk was 10% or higher, we should offer somebody a statin. But actually, the most recent iteration has gone along these lines, which is saying even if your risk is less than 10% and the patient feels like they have risk factors, we should still offer them a statin. Okay. Or they've got another risk factor like their blood pressure's high, for example. So the thresholds from the formal guidelines are all moving down. And those proponents of population treatment, like everybody should be on there's this idea of a poly pill. Everybody should be on a pill which lowers their blood pressure and lowers their cholesterol levels. And it should all start at the age of, say, 45. Mm-hmm. The guidelines didn't agree with that, but they're sort of coming together with time because, like you say, the evidence is the sooner you do it, the better. I mean, there was a recent trial or study, well, not a trial, that looked at the risk of dementia with statins. And that's also lower if you take statins, from a younger age. So there are additional benefits beyond heart attack and stroke. Dementia seems to be another one that potentially is lowered by taking statins.
So I guess thinking about the very popular longevity space now, statins should be one of the things we're thinking about before all of these kind of new untrialed medications.
It's got to be one of the top things that you can do. In terms of things you can actually modify, you can actually treat. Lowering your LDL cholesterol has got to be one of the top ones, along with blood pressure, if you want to avoid, or not avoid because you can't avoid, but reduce your risk of heart attack and stroke long term.
So here's another question that comes up for me quite a lot in clinic, and that is patients in the later part of life who have a high cholesterol and they're called into their GP or they're called into their doctor who recommend them a statin, and they're kind of 70, 75, and looking back, they've had a high cholesterol for a while, but maybe it's just been creeping up a little bit. And they come in to see me for an opinion about, is there a point? Because obviously your starting is to give you a cumulative risk reduction. So is there a point to starting a statin in later life?
So this is an area that is to some degree controversial. And the reason is older patients are often not included in the trials that we do. Okay. They often have a cutoff of like 70 or 75. So if you've got a statin trial, for example, lots of them would have excluded older people. And that's the same for blood pressure. It's the same sort of problem. But there's been some more recent evidence looking at the over 70s. And actually in the over 70s, statins do help prolong life in terms of recent evidence. And you're talking about treating it over, a couple of years to see that benefit. But there is evidence that is beneficial. And I think that, you're saying by 75, have you not just accumulated all of this furred up arteries? But because it can help reverse that, and because it can help stabilize those plaques, those areas where it's built up, I think that's why it has benefit. So I definitely think older people should not be excluded from treatments that reduce heart attack and stroke. Now, clearly, there are, as we get older and more frail, that becomes less certain. If people's life expectancy is quite low, clearly things that you need to take for a few years aren't going to be of benefit. If people are on lots of tablets and they have high pill burden, you're going to have to be very really think hard about which ones you're going to recommend someone takes and which ones they don't. And they're ones which are for prevention might not be the ones you aim for. You might be aiming for ones that are more symptom based. So that's on a case by case. As people get older and more frail, you might stop them. But I think for otherwise healthy,
healthy, independent,
exactly, people in their 70s and 80s, even 90s. My grandmother-in-law is 96, and she's doing really well. Would you say that she shouldn't be on a statin if we think it's going to reduce the risk of heart attack and stroke, even at that age? It's an interesting question. But in the main, I would definitely not withhold those medicines that we know have benefit.
And that even comes to not, when you say withholding it, you don't mean just stopping them, you mean even just initiating them.
Yeah, I would definitely consider initiating them. As I mentioned before, about 40% of over 70s are on statins. That other 60% probably should consider taking them.
Right.
At least consider and have that conversation, with their GP.
So this is a very big topic area, but what's new, kind of what's coming in this field of cholesterol management. And specifically, I think it would be good to hear it from an evidence-based perspective, because again, in this space, we're thinking about longevity, and there is so much out there on people experimenting. But I think for someone who's so attuned to the scientific studies, what is out there in terms of future treatments for cholesterol reduction?
So there are some new medicines that have just actually come out in the last few years, which are quite exciting. So one is, and I say exciting, as a clinical pharmacologist, I know most people might not find it very exciting.
It's your job
it's my job to be excited about it. So obviously statins are brilliant, but there are a small proportion of patients who can't tolerate statins. And in those patients, we used to be in a bit of trouble, because especially ones that have had a heart attack and stroke and you really need to lower their cholesterol, what do you do? And there is a drug's been out for a long time called ezetimibe, which works in a different way, which reduces how much your body absorbs from the diet. But there's a new one called bempedoic acid, which works in a similar way to statins, but doesn't cause the muscle side effects. And you can get it as a combination with this one called ezetimibe, and that's a good alternative, actually, for people who can't tolerate statins. The combination of the two can lower cholesterol by about 40%. So similar to sort of a starting dose of a high-intensity statin. So that's a really useful tool to have available for those patients who don't tolerate statins. I've had lots of patients who I've moved on to that, who weren't taking anything, and that's beginning to lower their cholesterol. But one of the coolest new drugs is one called inclisiran. And this is an injected drug. You take it initially every first dose, then 3 months, and then it's 6 monthly. So just one jab every 6 months can lower your cholesterol significantly. Now, at the moment, it is available for patients who have had a heart attack in the NHS. If they can't, if their cholesterol hasn't come down to the target that we want it with normal treatments like statins. But what's great about that is you don't have to take a tablet. And its side effect profile is amazing. It doesn't seem to have very significant side effects at all. And so that as an injectable way to lower your cholesterol is brilliant, because you can just forget about it.
And inclisiran this is PCSK9 inhibitors, aren't they?
Yeah. So there is a protein called PCSK9 which is involved in LDL. So it helps sort of remove LDL from the circulation. So it lowers LDL. And there are other drugs that target this PCSK9 protein as well. Inclisiran is this injectable one. It's an RNA-based drug, which is why you only have to give it every 6 months. There are other ones which are sort of monoclonal antibodies against PCSK9. So they're in more of the kind of specialist clinics. If you're in a specialist cholesterol clinic, they would therefore have that available to them. But this inclisiran is available for GPs to use. So I think that's why it's quite exciting. And I think that's a real interesting technology that we're going to see lots of drugs move on to. We've talked about LPA, and actually the drug that's been invented at the moment for LPA is the similar technology. So it will be an injection every few months, and it will lower your Lp(a).
So there are medications on the horizon that can help people who have good lifestyles but have this kind of genetically inherited, familial risk which is really hard to control through lifestyle.
Exactly. And that technology I think is going to be used in lots of different diseases, but it seems to work very well for lipids. It's very well for LPA, cholesterol, and I think that's where we may end up going. Fast forward 5-10 years, maybe we'll just go for a twice annual injection, and everybody's LDL will be really low, and will massively reduce the risk of heart attack and stroke. Who knows?
Well, I'm definitely going to go see my doctor after this to discuss statins. Key take-homes, before we finish, key take-homes for people watching about their cholesterol.
So know what your cholesterol is.
Yeah.
We haven't really talked about numbers, but know what it is. Don't be scared of statins if they're offered. Be informed.
Mm-hmm.
Look at the side effect profile. Look at what it's likely to do in terms of reducing your risk. Think about the lifestyle things that you can do to lower your cholesterol. So again, it's about diet. It's about trying to avoid the trans fats and the saturated fats as much as possible, and then having better profile in terms of polyunsaturated, and reducing sugar and alcohol as well, as much as you can do, and look at it as the whole package. It's yes, cholesterol is important, but also look at your rest of your cardiovascular health. Think about your blood pressure, your diet, salt, exercise. It's part of this whole package of things that you can do to reduce your cardiovascular risk, not just for tomorrow. This is about the next 10, 20, 30 years for a lot of the patients.
That's a great finishing point, because again, I see patients who are so focused on their cholesterol, which is mildly raised at 5.5, but they, are drinking way over the recommended limit per week, and they're not exercising, and their blood pressure's moderately high. And I'm trying to say, well, we can focus on the marginally elevated cholesterol, but there is so much more here to discuss as part of your risk.
Exactly. And it's about your long-term health.
Well, as always, you've been incredibly informative. Thank you very much for joining me.
Thanks for having me.